Welcome to another lecture series in immunization. I'm your host, Ken Wong. Let's begin. As you can see here, there are 11 vaccines that we have to cover. Let's go ahead with influenza. So we have 3 different vaccines for influenza: inactivated, recombinant, and live attenuated. As for inactivated, it's quite common for us to use. So majority of the vaccines that you gave, it's this form. And we have recombinant influenza vaccine, which used to be for people with egg allergy. That is because this vaccine was not created with egg. However, we'll talk a little bit more about egg allergy and the recent guideline. Next, we have a live influenza vaccine, which was actually not recommended last year. However, this year it's okay. Let's move on to the strains of influenza vaccine. As you can see, for this year's strain, we have either trivalent or quadrivalent. For the trivalent, it's this 3. As for quadrivalent, it contains this 4 strains. There's usually 2 strains of A and either 1 strain of B or 2 strains of B. Next, let's look at the efficacy of the vaccine. Generally, we do not know the efficacy until the beginning of 2019. But as you can see here, our overall vaccine efficacy for influenza is not that great. Last year was about 40%. However, having 40% efficacy is better than 0%. Next, we'll look into the egg allergy, whether there's any contraindication. So for 2018-2019 influenza season, there has been multiple studies that showed it is safe to give inactivated influenza vaccine to people with egg allergy. In the past, it used to be mild egg allergy, whereas the ones in severe form, you would have to give a recombinant. However, even with severe form of egg allergy now, it is recommended that we can give inactivated vaccine, provided that we're able to monitor the patient. Now let's go to high-dose flu vaccine. So people who qualify for high-dose vaccine would be age 65 or above. There's been study that showed that there's 24.2% more effective in preventing flu in adults age 65 or older. That is because it contains 4 times of antigen in the flu vaccine. However, if you do not have high-dose influenza vaccine, you can give a regular vaccine. Now let's move on to the next vaccine, which is pneumococcal. This is probably the most common vaccine that most of you will be prescribing. We have 2 kinds. We have Prevnar and Pneumovax. Prevnar is PCV13 and Pneumovax is PPSV23. The easiest way of remembering this is if you require a 13, you will require a 23. If you require both, 13 is given first before the 23, as 13 comes before 23. That's a way to remember it. One way of remembering when to give Prevnar is we have 2 C's here, which is not as commonly seen, which is cochlear implant and CSF leak, and then age 65, which is quite commonly seen, and also our immunocompromised patients. So again, people who require Prevnar are people with CSF leak, cochlear implant, age 65, and immunocompromised. Then, your more common patients who require a pneumococcal vaccine will be CHF, lung disease, diabetes, alcoholism, liver disease, cigarette smoking, and that is your Pneumovax. Something that we commonly forget that requires both pneumococcal vaccines, even though they are considered as immunocompromised groups, are people with chronic renal failure, nephrotic syndrome, malignancy, and also multiple myeloma. As with multiple myeloma, these patients will have functional IgG deficiency, hence they are more prone to getting invasive pneumococcal disease. Previous studies have been shown that in kids, giving PCV7 reduce invasive disease by vaccine serotype by 97%. Invasive meaning meningitis, bloodstream infection, and endocarditis. The other thing you have to take note is if we were to max out pneumococcal vaccine, the max Pneumovax PPS V23 you would give is only 3, whereas Prevnar in lifetime is only 1. Say, for example, a person is diagnosed with HIV at age 25. What you would do is you would give a Prevnar at age 25 and then a Pneumovax in 8 weeks. Then you can possibly give another Pneumovax in 5 years. And when a person is 65, you would give another Pneumovax. So as you can see here, Prevnar was given at first, so this is the one with 13, and then 8 weeks later you give a PPS V23. 5 years later you give another PPS V23, and then when this person is 65 years old, you give another Pneumovax. So hence 3 Pneumovax in a lifetime and 1 Prevnar. Now this is considered as immunosuppressed population. However, if you were to give a person who is 65 years old, non-immunocompromised, or should I say immunocompetent, you would give a Prevnar, which is PCV13, and then you would give Pneumovax a year later. So immunocompetent patients will usually get Pneumovax in a year as opposed to 8 weeks. Next, we'll move on to shingles. So we have 2 different vaccines in preventing shingles. One is Zostavax, which is live, and Shingrix, which is not live. Hence, the nice things about Shingrix is you can give it to people who are immunocompromised, such as transplant patients, people on biologics, HIV with CD4 count less than 200. It used to be that FDA approved Zostavax for age 60 and above. They reduced it to 50, and now after Shingrix is out, age is 50. Amazingly, the one that is non-live, Shingrix, has great efficacy, as you can see here, 97% for age 50 to 59, and it's still in the 90s at age of 80 and above. Hence, the ACIP recommends that a person should get Shingrix even though after a person has received Zostavax. Shingrix is a 2-shot vaccine. They are both equally in price. Because it is so efficacious, you will tend to have a little bit more local reaction with Shingrix compared to Zostavax. So something that you might want to warn your patient. Next, we'll move on to HPV. So for HPV types, we have the oncogenic type and a non-oncogenic type. For non-oncogenic type is type 6 and 11, with oncogenic types are 16, 18, 31, 33, 45, 52, and 58. Oh, and 31 as well. As for cervical cancer and anal cancer, is about 70% of cervical cancer is from type 16 and 18, 80% of anal cancer from 16 and 18, whereas for the rest is contributes about 15% for cervical cancer. As for non-oncogenic types 6 and 11, contributes about 90% of genital ward. As for vaccination, there is a Gardasil 9 that contains all the strain. It is recommended for female through age 26, as for male is through 21. However, if the male population is either HIV positive or an MSM, you can give it up to age 26. Some exciting news is very recently, in October 5th of this year, FDA actually approved that HPV vaccine can be given up to age 45. Next, we'll move on to tetanus. Majority of our patients should have already received primary tetanus shot. However, if the person has not received the 3 doses in the past, you can provide that. Usually you would start off with Tdap, the one with pertussis, then followed by a TD 4 weeks later, and then another TD in 6 to 12 months later. Tetanus vaccinations is given every 10 years. If your patient has already received the primary tetanus vaccine and not sure if he or she had received Tdap, then you would give 1 dose of Tdap in replace of the regular tetanus shot, if he or she is supposed to get one. In pregnant patient, what you want to do is you want to give Tdap at the 3rd trimester of the pregnancy. What you want to do is you want to give it in every pregnancy. Say a person does have 3 pregnancy in her lifetime, you would want to give 3 Tdap in each pregnancy, even when she has received one the year before. The rationale behind that is to maximize transfer of maternal antibodies, especially pertussis, and closer to the birth. Next, we'll talk a little bit about tetanus prophylaxis. You would occasionally see this in your clinic or even in your exam, especially if a person has a minor cut or a contaminant wound. The definition of contaminant wounds is wound contaminated with dirt, feces, soil, or saliva, or a type of wound that is puncture, avulsion, or wound resulted from missiles, crush, burns, or frostbite. So as for clean and minor wound, people who receive less than 3 doses of tetanus or not sure, you want to give a tetanus vaccine, but without the immunoglobulin. Now, if the person received 3 or more doses of tetanus toxoid, then you would only give the tetanus vaccine if it's overdue after 10 years. And it's not necessary to give an immunoglobulin. As for contaminant wounds, if a person has never received a primary tetanus vaccine or not sure or less than 3, then of course you would give a tetanus vaccine and also the immunoglobulin as well. However, for the person who had received primary tetanus vaccine before, then it's only given if the last dose is 5 years or more. Next, we will talk about meningococcal vaccine. We've got 2 types of meningococcal vaccine. We've got this, MenACWY or MPSV4, and MenB. So for population that requires both vaccination would be people with anatomical or functional asplenia. These people would need to receive any vaccinations that covers for encapsulated organisms anyway. So that includes pneumococcal, H. flu, and meningococcal. Other people who require both of these vaccines would be microbiologists who is routinely exposed to Neisseria meningitidis, patients who are receiving eculizumab, patients with persistent complement component deficiency. These patients usually will present with young age that comes in with repetitively for Neisseria meningococcal meningitis. The other high-risk population would be military recruits as well. Of course, you want to protect them because they are exposed to a lot of different organisms. The next more common population that you would give meningococcal vaccine to, especially the MenACWY, will be HIV population, adults traveling to endemic area. By the way, for endemic area, you can actually check CDC website for vaccination recommendation. So first-year college students aged 21 years or younger who live in a residence hall will need this vaccine as well. Otherwise, there's not a whole lot of recommendation for MenB. Of course, in an outbreak setting, depending on which type of meningococcal that is causing the outbreak, vaccinations of that particular type should be given. Next, we'll be talking about measles, mumps, and rubella. So generally, you want to administer 1 dose of MMR to people who do not have immunity. So the definition of being immunized with MMR is anybody that was born before 1957, has a documentation of MMR being received, and also a positive titer. These are the special population that requires an MMR vaccination if the population does not satisfy the definition of being immune. So anybody who is pregnant, you should never give a live vaccine or MMR to a person who is currently pregnant. However, you give it after the pregnancy, especially before discharge from the hospital after delivery. Then you want to cover childbearing age who's not immunized with MMR. Next would be HIV population whose CD4 count more than or equal to 200 with a negative titer. You do not want to give a live vaccine to an HIV person with CD4 count less than 200 because that's contraindicated. And also a healthcare professional that was born in 1957 or later. Especially they do not have evidence of immunity. Next, we'll talk about chickenpox or varicella. So the definition of immunity for chickenpox or varicella is U.S. born less than before 1980 or have received 2 doses of varicella 4 weeks apart, history of chickenpox or shingles, or a positive titer. Population who will need a chickenpox vaccine will be pregnant population. Again, this is a live vaccine, so give it postpartum before the person is being discharged from the hospital. Healthcare worker without evidence of immunity. And lastly, HIV population with CD4 count more than or equal to 200 without evidence of immunity. Again, this is a live vaccine. You do not want to give it to pregnant women or HIV population with CD4 count less than 200 or other severely immunocompromised or immunodeficiency population. Next, we'll talk about hepatitis A and B vaccination. You might encounter quite often as well, especially hepatitis B. Let's start off with population that requires both vaccines. Anybody that travels to an endemic area of either Hep A or Hep B should receive either or both if they both have high endemic area for both. MSM should require both, injectable drug user, chronic liver disease as well. So those are your 4 population that requires both. Next, we'll look at just hepatitis A. Will be patients with clotting factor disorders, people in contact with international adoptee. For example, household or regular babysitting during the first 60 days after arrival in the United States from a country with a high or intermediate endemicity. Administer the first dose as soon as the adoption is planned. Next will be employees working with non-human primates with hepatitis A. Then next will be patients who are exposed to hepatitis A. As for hepatitis B, patients with HIV infection should receive hepatitis B. If they are MSM, they should receive both. Next will be percutaneous or mucosal risk of exposed blood. Now these are especially with patients who live with positive hepatitis B family members. Now we're talking about hepatitis B surface antigen positive patients. Say a patient's spouse has a positive hepatitis B surface antigen. That patient, the one without hepatitis B, should receive hepatitis B vaccine. Next would be diabetes. This is because they check sugar quite often. Some of them use insulin. All these are high risk for hepatitis B transmission, especially if the needle or lancet is contaminated with hepatitis B virus. For example, used by someone else that the patient just doesn't know. Next would be patients requiring dialysis or peritoneal dialysis. Injectable drug user, again, they should receive both as well, Hep A and Hep B. And last but not least, healthcare providers such as us. Next, for sexually exposed patients with hepatitis B will be hepatitis B surface antigen positive partners or sexually active and not monogamous. Also, people seeking for a sexually transmitted disease treatment and MSM as well. Again, MSM should receive both Hep A and Hep B. Last but not least, for population that receive care in high proportion in hepatitis B, so these are facilities such as facilities that provide STD treatment, drug abuse treatment, and prevention services, hemodialysis centers, institution for developmentally disabled persons, healthcare settings targeting services to injection drug users, HIV testing centers, or correctional facilities. Last but not least, H-flu. As discussed before, these are for people without spleen. That could be either anatomical or functional. If a person is undergoing elective splenectomy, preferably to administer this vaccine 14 days before the splenectomy. Again, the other vaccine for these populations are pneumococcal, which is your Prevnar and Pneumovax, meningococcal, and H-flu. The other population that requires H-flu would be patients undergoing stem cell transplant. Ideally, you want to administer this vaccine after successful transplant, 6 to 12 months after successful transplant, regardless of their vaccination history. This is because you want to wait until their immune system is active before you provide this vaccine. Alright, that is all for immunization. We have 11 immunization, remember. We've got flu, pneumococcal, shingle, zoster, HPV, tetanus, meningococcal, MMR, chickenpox, Hep A, Hep B, and H-flu. Thank you for listening.